on this session, we're going to cover quite a bit actually. So I just want to take you through some of our speakers, and then we're going to hand over to Claire, who's going to give us that BSOL context around why this is so important. So we've got obviously ourselves at West Midlands Academic Health Science Network. So I'm Dan Hodgkiss. For those on part one, you'll have seen me then. But I'm the Deterioration Programme Lead across the West Midlands and supporting this piece of work. We'll hear from Caroline as we go through the call. And Caroline's our quality improvement lead. She's done a lot of work with care homes across the region already and supports deterioration and med safety national programmes. Sarah, our events and communications manager, you've just heard from Sarah, and Sarah will support in the background with any tech, etc. For us as well. And then we've got Nazrin Khan, who's our improvement science manager, and she kindly goes through the slides whilst we're doing this, but supports managing deterioration more widely. And then we've got Kelly Owen, a clinical team leader, and Sarah Bites, who are going to talk us again through a highlight and recap of the use of Restore 2. We've got Nick Dale, who I can see has just joined us, so welcome Nick. And he's going to give us a case study example of a care home where Restore and the tools were used more recently. Then we've got Camilla, who's a clinical education lead at St Mary's Hospice, and she's going to talk us through advanced care planning, personalised care support plans, use of respect documents, etc. And then we've got Alka, and Alka is one of our care home managers in Solihull, but equally is the deputy chair of the Deterioration Safety Network. So she's going to give us equally a case study example from her care home perspective of using the tools. So welcome everybody, but I'm going to move us on to the next slide and introduce you to Claire Underwood. So Claire Underwood's the Deputy Chief Nurse for Birmingham and Solihull CCG, but is the chair of the Deterioration Network, who's just going to give us a context. So over to yourself, Claire. Thank you.
You will remove that slide, won't you, when I look like a bit of a goldfish, and I've changed the colour of my hair. So are you able to take the slide off, just so that I don't have to sit and look at these aren't my slides, are they? I'm not being expected to speak.
As if you start sharing slides for a second.
That's fine. Hello everybody. As Dan has already highlighted, my name's Claire Underwood and I'm Deputy Chief Nurse for Birmingham and Solihull CCG. I'm not sure how many people we have from care homes. Are you able to put your hand up if you're from?
I've just asked people to pop in the chat box if they're from a care home. From my quick look, I think we've only got 6 people from care homes on the call at the moment. Or maybe 7.
So
yeah.
I was just looking at the chat box. Okay, well that's really good though. So that's really, oh thank you, that's good. See the thumbs up. So we've got Kathleen. Are you able to just say where you're from, Kathleen?
St Joseph's.
St Joseph's Home.
Lovely, thank you, welcome. Stephen, are you from a care home as well?
Yes, from Meadowrose Nursing Home. I'm the manager of Meadowrose. I think I've seen my colleague as well, Bilk, is here as well.
Oh, lovely, welcome, fabulous, thank you. I'm trying to think of other names that you didn't mention now that I can see on the screen.
Karen Williams.
Karen.
Rachel Wood. Stephen's just spoken.
Karen, are you able to say where you're from?
Burwood, she's put in the chat. Burwood Court Care Home.
Lovely, welcome. And Rachel?
Rachel's just having some audio issues. I'm just messaging her privately.
She's put Hafford Nursing Home.
Hafford.
Yeah.
Okay, lovely. Okay, that's lovely. And it's just nice just to have a little bit of understanding because it makes it a bit more real. So I'm not sure if you attended the first session, but hopefully you did, and it's a follow-on to that for you. But obviously the purpose of this is to support care home staff, to support yourselves, and ultimately to support the residents that you're caring for, in order to deliver the the best care possible. This clearly is only an element of your work, and there's lots more to it, but we want as a system to make sure that we can support you as best we can. We are aware that there are gaps across Birmingham. So Solihull at the moment has got fully covered care home support team, whereas Birmingham is slightly altered, and there is a proof of concept. Excuse me, I've got two dogs fighting in the background. Stop it. I'm caring for my friend's dog. The husband's very poorly, so I've just shut one out, so that should help. So basically, the value and importance of this is extremely important to us as a system. Currently, as you probably are aware, we're under significant pressures from an urgent care perspective. But that aside, irrespective of that, this is about helping you to care for the residents as best you can and to keep them in their homes and your care homes as safely as possible. Of course, at times, there is always the need to convey and transfer people to hospital if required, but we would hope that with the use of the Restore 2 tool or any escalation tools that you're using, and then the service support guide, that we would minimise that as much as possible. So I would be really keen to hear if you could add to your chat anything else that would be helpful to you as organisations or as teams, that you think if we'd got this, that would really help us to keep people or residents in their homes or help us do our jobs better. So, you know, aside of the Restore 2 tool as well, tell us what else it is, not just training or whether it's a piece of equipment, whether it's something, a phone line or something. You know, I think even though the aim of this session is to talk about Restore 2 and to update you as to where we're at, it's also really important that, given that we're in this situation from an urgent care perspective, and the challenge that I'm all sure you're all experiencing if you've called for ambulances for anybody, and the delays that are being experienced, that we try and support that and support you as best we can. So we are really committed to doing that, and I personally am very committed to doing that. So please tell us and tell us as much as you can, and I'll put my email and phone number in the chat, and if there's anything I can help with, or you tell your colleagues or friends that can't be here today, please share that with them, and we'll gladly support them too. So I hope that's you know, proven to you our commitment to you. We are very committed to supporting you. You are as much an important part of the NHS family as anybody, and from, you know, a health and social care perspective. So it's really important we make sure that we wrap services around you in order for you to do your jobs as best you can. I won't say any more because I'm repeating myself a little bit, but as I say, if there's anything that I can help with, please get in touch, and I hope that this session is really useful to you and something that you can take away and help, you know, you do the jobs as best you can.
Thanks very much, Claire.
No problem.
So Naz, if we can bring the slides back up, please. And I just want to underpin that with the national context. So Claire gave you a snapshot of what's happening in Solihull. I just want to underpin that. So for those that joined in the first webinar will be familiar with this slide. Nationally, there is a programme called Managing Deterioration, and that's a safety improvement programme. So it's one of 5 national programmes that we are working towards. And what we essentially want to do on that is reduce deterioration associated harm across the whole pathway. So whether that's within your homes, within primary care, and equally into secondary care and hospitals, etc. So one of the key areas of that is working with what we call non-acute settings, and the non-acute settings includes social care, so domiciliary care, care home providers, supported living, etc. And the aim of that is to, one, skill you up as a workforce so that you're able to recognise deterioration early and that you're able to escalate it. And that's using a range of tools. So we call them tools, but that's like a soft science tool, or a communication tool like SBARD, etc., which we'll go through again and recap shortly. Now in Birmingham and Solihull, what we're using is what we call the Restore 2 tools. So hopefully that's quite familiar now to some of you. If it's not, then don't worry, because part of the sessions is about skilling you up with those. So with that in mind, the national aim is that 60% of all care homes by the end of March are using those tools proactively for all of their residents, because we know that you're best placed to recognise deterioration. You know your residents far better than we do, far better than the supporting teams do, because you're seeing them every single day. So you're seeing those subtle changes, you're seeing those changes in behaviour or physical condition. And then we need to support you so that you can escalate to the most appropriate team or service at that point in time. And that's not always 111 or 999. So we know that far too often where residents go into A&E, for example, it's quite an anxious time, it's quite a fearful time for that resident, especially if they're there for a number of hours. So we want to limit that to only when they absolutely need to go for that emergency. Ideally, what we want is the community teams around you to come and support, so that that resident gets the care they need, ideally to stay within their preferred place of care. And that's where this sort of program works. We're equally working with all of your community teams and your primary GP teams to look at how they better support you. So we know from the primary care DES contract that there was then a mandate for GPs to be allocated to care homes, and that you would have one MDT sessions. Now we know that across the region they're happening, but potentially not all as great as some of them are. And we want to make sure that they're really useful for you, that you can escalate, and that you can absolutely have those critical discussions earlier. So that's the sort of wider context nationally. It all sits in what we call the PEER framework. So prevention, identification, escalation, and response. So that's the 4 areas that we're using it across these sessions. So we could have the next slide, please, Naz. And here you'll see how we've broke that down. So for those of you that did join in the first one, again, this will be quite familiar. But initially, it's about that frailty recognition, understanding in our residents how frail they actually are when there's changes to their frailty. For example, if they're having recurrent falls, or if they've been in hospital and they come back to you quite different than they were when they went in, so they're needing more support, more assistance, etc., especially mobilising or eating and drinking, etc. So absolutely, we should be all assessing all of our residents for frailty across the whole country. It is the expectation, and then we can start planning far earlier than waiting until that resident is severely or very severely frail. And I'm sure that Camilla will pick up on some of this in her talk later in the session around that advanced care planning, making sure that we've got the right plans in place. And that links to that 4th box on the slide, if you like, so that end of life planning or personalised care support planning. But in between that, it's really important that we recognise the soft signs, and then we recognise acute deterioration. So certainly for nursing homes, we would expect there to be, undertaking of observations. So knowing the baseline for all of your residents. So is it that they have a national learning warning score of 0 or 1? And then you can see if there's deterioration away from that baseline and norm. Or equally, if you're a residential home and you do partial observation like temperature or oximetry, etc., that what's the norm for that resident? So if we could just have the next slide, please, Nat. So last time in the first webinar, we talked about understanding frailty. So if we can have the next one again, please, Naz. And I'm not going to dwell too much on frailty within this session. If you haven't seen that, or you weren't part of the first session, and we can send you the recording after this for that. But essentially what we said is that there's been an agreement that we will all use what we call the Rockwood Clinical Frailty Scale. So Rockwood takes you through different levels of frailty and is a very quick assessment so that each of our residents, we get an idea of their frailty level. It also aligns to the GP's comprehensive geriatric frailty assessments. So because it aligns to that, and we know that West Midlands Ambulance Service use Rockwood for frailty, that makes it easier then, if we're all using the same tool across BSOL, that actually then the response you get from the ambulance service or your GPs is one that's familiar, because they know that and use the tool as well. And that's why Rockwood was chosen predominantly for BSOL. And it's actually one that's used across the whole of the West Midlands. So really important for those that are just starting to do their quality improvement projects. If you're starting to do frailty, and we'll look later in the session at, out of those 5 or 6 care homes, whether you're doing this already or whether it's something that you're working towards. So there were quite a number of care homes in the first session that said after the session they wanted to go back and assess all residents' frailty within the next month or two. And that's a really good starting point for this piece of work. Understanding that baseline is really important. So I'm going to move us on to the next slide. And at this point, I'm going to hand us over to Kelly Owen and Sarah Bates, who's just going to give us a brief recap of the Restore 2 tool and how that's useful to pick up soft signs, acute deterioration, and then how to escalate using SBARD. So thank you, Kelly and Sarah.
Thank you. So I thought I'd start with just a brief overview of what the service does in Solihull. So I'm Kelly Owen, I'm the clinical team leader of the Support to Care Home team, and that team provides clinical guidance and education to both residential and nursing homes. Currently we have 3 community matrons who are each aligned to a primary care network, and the clinical leads who have been identified for each home, and therefore each care home will have a named matron contact. They endeavour to support staff to feel empowered and confident in the care that they deliver. They'll work with staff and residents who have complex, long-term conditions, and will support the home to develop proactive preventative care plans to help you avoid any unnecessary admissions and get the right care for your residents. We also have access to a tissue viability nurse through the service who can help with education and complex wounds. And then we have 3 clinical educators who can offer training, both formal and informal, to include coaching and facilitation in areas such as end of life, dementia delirium, frailty, falls, pressure prevention, wound care, hydration and nutrition, catheter management and diabetes. And the team support homes also to embed quality improvement tools to help improve patient safety. So for example, the Restore 2 tool, which Sarah Bates, one of our clinical educators, will go over now with you. Thank you.
Hi, can we have the next slide, please? So I'm Sarah Bates, and as Kelly's just said, I'm one of the clinical educators, and one of my biggest pieces of work has been to try and get Restore 2 implemented in the Solihull care homes. So just to give you a brief overview of Restore, I did a more in-depth talk on it on the first webinar. So if you were there, hopefully this will all be a refresher. If not, as Dan said, you can ask for the recording and that can be sent out, and it gives you a bit more information about Restore on there. Essentially, Restore is a deterioration tool designed for use in care homes to aid the recognition of deterioration, those early signs of deterioration, to take observations, to respond and to escalate as necessary. It really was designed as a common language across both health and social care, so that when talking amongst ourselves, health and social care workers, we can get that message across concisely and get the help that we need for the residents as quickly as possible. So Restore comprises soft signs, the recognition of those early subtle signs that people tend to make when they're becoming unwell, taking observations on the News 2 chart, calculating that News 2 score, and then escalating through the guidance from the escalation tool using the SBARD communication tracker if you need to then make that escalation. Next slide, please. So the very front of the Restore 2 tool goes through those subtle soft signs that we talk about, those early changes that people make to their behaviour when they're becoming unwell. It's an aid memoir for your staff to be reminded what those soft signs are, and if they spot them, to remind them to use the Restore 2 tool to then take the observations. Next slide, please. There's also a mini restore, so that can be used if you don't use the full restore. If you're not a care home that uses that does observations, sorry, you could use the mini restore, which just goes through the soft signs and triggers you to escalate to a healthcare professional if you notice any of these soft signs and your home doesn't do observations. You don't necessarily have to use the full restore to do the observations. You can use the mini restore and then escalate once you notice the soft signs. Escalate, as I say, to a healthcare professional that way. Next slide, please. Oh, so that was very quick. We got to mini restore before I really finished about restore. Thank you. So the escalation, you've then got the SBARD that we've talked about, which is the communication tracker at the end that you would use to then speak to the healthcare professional or whoever it is you're escalating to. You'd use the communication tracker to hand over. And I'm now going to hand back to Kelly to go through with you the service guide that we've got for both. There's one for Solihull and one for Birmingham, and Kelly will just talk you through that. Thanks.
So yeah, just briefly, I think the one we have in front of us now is the Solihull service guide, and this has been put together. There is an equivalent one for the concept homes in Birmingham, and it's just a really useful document here because it's if you need advice for your resident, who do you need and who should you call. So it has listed on there all services from the support to care home right the way through to 111 999, rapid response and services and pathways that can support you, giving you some details why you may call them. So this is a really useful document to have in the home, and I think some of the stories that we'll have later in the talk today actually highlights how this has supported some homes in Birmingham to date to make the right call and get the right support for their resident. Thank you. Next slide, please. I think this is the Birmingham one, so that's just an example of that one there. And then next slide, please. Brilliant. So I think I'm going to hand over to Nick, if he's here, if that's okay. Thank you.
I am sorry. Hello, sorry, I apologise for my psychedelic background, everyone. It's not letting me put a filter on myself. So, hello, my name's Nick Dale. I'm one of 3 advanced clinical practitioners who currently work within the proof of concept care home pilot within Birmingham, Birmingham Community Healthcare. So I just wanted to share a recent case study of working alongside Hollywood Care Home, which is within Erdington. I was hoping Julie Beard, the manager, was going to join us and just also give some feedback in regards to this case, but it doesn't look like she's been able to. So if we can just go on to the slide and I'll just discuss it. Oh, all right. Obviously, this is the slide. So it was just a feedback about Hollywood had a recent outbreak of COVID. They had 3 cases. They were initially very stable residents, and they were being supported by ourselves and Public Health England to ensure everything was in place, and the root cause of the outbreak was established. So we provided them with the contact numbers for our service. We provided them with the deterioration tool and the Restore 2 tool. And we provided them with the contact number for our service and also the early intervention care team service. Then a few days later, what happened is the 3 residents actually did become a little bit unwell, not a rapid deterioration, but a concern that prompted the care home staff to check their observations in line with the new score, which showed the oxygen saturations had dropped, but not a significant amount, but enough to trigger the soft signs, and therefore they wanted some support to review those residents. They did contact their own GP, who unfortunately advised them to ring an ambulance for each resident. But because they had the tools, the care home didn't feel that was initially appropriate, and followed the deterioration tool and contacted early intervention care team. But due to a telephone problem with EICT that day, we were unable to get through. So they contacted ourselves. We arranged to go out within a 2-hour response. We were able to examine, as advanced clinical practitioners, the 3 residents and establish that they were safe to be treated within the care home with ongoing support and antibiotics where necessary. So it was really to highlight the good work of the care home staff in using the appropriate tools and the escalation processes, and because they knew the residents the best themselves, knowing that the right thing to do was not to ring an ambulance. So it was really just to share that with everyone here, and it also just to say it's good to see the St. Joseph's team are also on the webinar, so they're doing some really good work as well, and it's been great working with them. I don't know if they want to add anything about how they feel the proof of concept pilot and the tools are going. Sister Kathleen, sorry to drop this on you. Or Nuala, are you there? No,
Hi,
that's
Nick.
hello. How are you both?
Hi, Nick. Yeah, we're fine, Nick. Obviously, we're just going to start the Restore 2. We do use News 2, and we hope to develop it into the full programme in the coming weeks, hopefully.
And your visits are invaluable in coming in and supporting us as well with the doctor as well.
Brilliant. Thanks for that. I didn't mean to drop that on you, and I didn't pay them. But St. Joseph's is going really well because they have a really good GP support weekly ward round, which is obviously what we hope to get within all the care homes within Birmingham. So thanks both for feeding back. Any questions in regards to the case study? Oh, Claire?
Sorry, it's quite hard this when you're used to navigating a different system and then you're using this one. It's quite hard to find your hand, isn't it? And all this business, your video, but never mind, we got there. It's not a question, Nick. It was just to add, I suppose, just from the primary care element and your MDTs and that recognition of the tools by GPs and that support to care homes. We are picking that up as an action as well, as part of this work, in order to try and get GPs to use it as part of their language and discussion with yourselves, so that when you're doing it, then at least they refer to it as well, and it can be helpful and supportive, and not the opposite as happened in this example where the GP suggested that an ambulance was called. So alongside this work, we are working on that, and that's really important to us as well. So it was just to provide that assurance.
Thank you.
Got to try and lower my hand now.
But if there's no more questions, but obviously otherwise people are free to contact us via the Deterioration tool. Our contact numbers on there, and if I can be of any assistance at all, I'm sorry, I feel I've really rushed that, but thanks again all.
Thanks, Nick. That was great. So we'll now move on to Camilla. who is going to talk to us about advanced care planning. So thanks, Camilla. We'll leave it to you now. Thanks.
Thank you so much. Hopefully you can all hear me. So my name is Camilla Barrow. I am the Clinical Education Lead at Birmingham St Mary's and John Taylor Hospice. We are a teaching hospice and we do a huge amount of teaching and learning from our care homes. So I'm delighted to be invited today to come and talk to you about advanced care planning. Before we go on to the next slide, we'll notice that it's advanced care planning. This is care planning that happens in advance. It's not advanced with a D at the end. It's not something that you need to have advanced skills to do. So it is advanced care planning. Before we go on, this is obviously aimed at our care home attendees today. Is advanced care planning always about resident choice or patient choice? Just put a yes or no. This is a very safe environment. I'm going to be really honest, there's not a particularly right or wrong answer to this question. I just want to get a bit of a flavour for what your thoughts and feelings are around advanced care planning. And I am making the assumption that you've got some idea, you might have heard the words advanced care planning, had some exposure to it. So we've got patient choice. So I'm being a bit cheeky here because I'm using the word always patient choice. Is ACP, which is obviously the acronym for advanced care planning, patient choice? So thank you, Stephen. You've given patient choice. Anybody else put something into the chat? You can just give me a straight up yes or no. I won't be picking on anybody, I promise you. And like I said, this is a really safe space. So if you just let me know, we're going to come back to that in the chat a little bit later, and I may be able to answer some of those, the rationale behind your answers as we go through. So let's move on to the first slide. This is a whistle-stop tour of advanced care planning. Normally, as a rule, we would spend a good few hours discussing this subject, and I'm going to try and achieve it in a very short period of time. So can I have the next slide, please? Thank you. Advanced care planning. So what is it? Advanced care planning is a voluntary process. We must always remember that, involving discussions about future care between an individual and those who provide care for them. So, for example, nurses, doctors, care home managers, or a family member. Make note that actually advanced care planning is not owned by us healthcare professionals. It is owned by our patients and our residents. We are merely the vessel or the vehicle to allow these conversations to be heard and to communicate that across the people that are involved in the care of that person. So that is what it is. Let's have a look at the next slide. We're going to watch a very brief 3-minute video. We'll have a quick discussion about it afterwards. They say it better than me. It's from the GSF.
Advanced care planning in 5 simple steps. Advanced care planning is a way to think ahead, to describe what's important to you, and to ensure that other people know your wishes for the future. It's about helping you to live well up to the end of your life. Thinking ahead, discussing with others, and writing things down means that your wishes are known and respected. So if you become unwell or can no longer speak for yourself, you are more likely to receive the kind of care you want in the place you choose. Advanced care planning is a very simple process. It's just 5 steps. Step 1. Think. Think about the future. What is important to you? What would you want to happen or not want to happen if you became unwell? Who would speak for you if you couldn't speak for yourself? Step 2. Talk. Talk with family and friends. Make sure they understand and are happy with your choices. And ask someone you know to be your spokesperson, to speak on your behalf. Step 3. Record. Write down your thoughts or ask someone to help you record your wishes as your own advanced care plan. There are different ways of doing this. You could use your local GP's form, the GSF Thinking Ahead tool, or another advanced care planning document. Or you could video it and store it online. Whatever method you choose, make sure those that care for you know about it and can find it later. It is also a good idea to use a legal form called Lasting Power of Attorney for Health, or LPOA. Step 4. Discuss. Discuss your plan with those that look after you, your GP or nurse or someone from your care home, hospital or hospice. Tell them what's important to you, where you prefer to be cared for, and the kind of things you would like to happen to you. This is known as an advance statement. You should also discuss what you don't want to happen, known as an advance decision to refuse treatment, or ADRT, and what to do in an emergency, for example if your heart suddenly stopped. This is known as a resuscitation DNAR, or respect discussion. Who would speak for you if you couldn't speak for yourself? Make sure they know about your spokesperson, or LPOA. Step 5. Share this information with others who need to know about you, through your health records or some other means. Your healthcare team will make sure it is shared with others involved in your care. As time passes, your situation can change, so it's important to review your advanced care plan regularly. If you need to update it, it's best to discuss it with your doctor or nurse. You can do advanced care planning at any time, but it is especially important towards the end of life. It will help you to get the care you really want and live the life you want to lead. Just remember the 5 simple steps. Think, talk, record, discuss, share. The Gold Standards Framework, enabling a gold standard of care for all people nearing the end of life. Visit our website if you want to know more about us. If you want to know more about Dying Matters, see their website here.
Thank you. Thanks. We'll go back to and we'll have the next slide. Before we move on and talk about the why we do advanced care planning, that video, as I'm sure you've just seen, I'm hoping you all got to view that. I could see in the chat, I'm not too sure whether some of you lost. It is embedded into this PowerPoint, so do go back and review that amongst your teams, share it with your network. I think it is a really, really useful tool for a patient facing. It doesn't make anything sound particularly frightening. It doesn't use overcomplicated jargon. I think it's a really nice video if you thought it'd be good to share not only with your staff but also with your residents as well, if you feel appropriate. So why do we do it? Well, we do it to facilitate discussions about what to expect. We do it purely to allow our residents and our patients' preferences to be shared and followed. As I said, and I'm going to keep repeating it, this is a vessel. We are a vehicle to allow somebody to share their thoughts and their feelings about what they would prefer for the future, what matters to them, and to prevent any unnecessary or inappropriate interventions. So we are talking about when a resident potentially loses the capacity to consent to what they would want to happen, that we have something solid, that we've had these conversations, we know what this person would have wanted when they had capacity. So to prevent unnecessary or inappropriate interventions, so be that hospital admissions, be that inappropriate treatments that they would not have wanted. It's for us to focus on the things that are really important to that person. So, and we know by doing that we improve the outcomes, and we know by knowing where a preferred place of death or a preferred place of care, that not only does that improve the outcomes for our residents and our patients, it also lives on after their death. We know that if we have, particularly around patients that or residents that relatives or carers have perceived to be an unpleasant death, or a death not in the correct setting, or a death with not the right people around, that lives on in our grief. And it is what we would say a real red flag for complex grief and bereavement, and that brings, obviously that goes on beyond the person that we're talking about today. So it is such an important thing that we feel empowered to be able to help our patients and our residents to do. If we have the next slide, please. So this is the process of advanced care planning, and there are 3 components. And as you will see from this diagram, it's just a very visual diagram. To be able to begin good advanced care planning, we need to be able to identify the right patients and residents that this is most relevant for and prioritise. This is everybody's business. This is not just a GP's role. This is not just a registered nurse's role. Advanced care planning should be everybody's business. If you are in contact with patients or residents that are identifiable, then we should all feel empowered and all receive the right training to feel that we can start and begin these conversations. So we need to know how to have the conversations, how to enter into those conversations and try to manage them well. We then need to look at the documentation and the communication around those conversations, how we share that information across the healthcare team, across the system, to ensure that those voices of the patients and residents are heard. We do need to review it. This is not a one-stop shop. You don't do it once and never do it again. Patients and residents, they are allowed to change their mind. They're allowed to change focus. Things change in our lives that changes the perspective of what we wish for. And as our health changes, the things that are on offer to us as well change. So we need to make sure there is a good review process. We just have the next slide, please. So I said this is a whistle-stop tour, so we're going to quickly look at identification. I can see that obviously from your previous meetings, you've talked about the Rockwood scale, and you've obviously got other tools as well, but I'm just going to mention some of the palliative care tools that we use to identify a patient that maybe be an indicator for us to want to start these conversations or to initiate these conversations to take place. So if we go to the next slide. We use certain tools, no shock here. Everybody's got a tool for everything it feels at the moment, but we do use prognostication tools such as SPICT, which I'm going to show you very quickly, and it might be something you want to look at later. It isn't very difficult to embed into practice, SPICT isn't, and it's a really useful tool to be able to identify somebody that is palliative or end of life, which then would give you that indicator to want to maybe open up these conversations. Anybody that has a diagnosis of a progressive or life-limiting illness would certainly fit into a patient or resident that you would identify. A diagnosis where capacity may be lost, so our dementia population, our MNDs or Parkinson's, those type of illnesses where the trajectory, we are aware that the trajectory possibly means that that patient or person would lose the ability to share their thoughts and feelings with us. Where we've seen a change in deterioration, so potentially you might be looking after somebody who has been having active treatment for their disease and that active treatment has now stopped. That is a real indicator to want to open up these conversations. But also it could be somebody who's maybe having more falls, or who is having more having to see the GP more often, or is needing to, or has had more frequent admissions. So they're also real clear indicators. So when you're receiving a resident back into your care home after they've come home from a hospital admission, a relevant hospital admission that was hopefully beneficial to them, and they've come home and they are hopefully feeling better, that is still an indicator to want to open up these conversations. A change in circumstances, I'm sure it comes as no surprise to you. A change of circumstances in regards to where they're living is a big alarm bell should be going off, that these conversations need to be happening. But also a change in circumstances. They may well be a resident within your care home, but if they have had a recent bereavement of either, a spouse, a close friend, something like that, that may also be a reason to start those conversations as appropriate. And of course, patient initiation. Many patients are sitting on these conversations. They're stuck inside them. They don't know what to do with their information. They don't know who to share that with. So do not be surprised. Sometimes it can feel like we are always the indicators and the initiators of them, but you'll be so surprised as we get more and more confident at having these conversations. So many patients want to share this information. Next slide. So this is your SPIC tool. So it's a supportive and palliative care indicator tool. I'm not going to go through it in great detail because it's really wordy, but print it off, have a look at it. pop it up somewhere. It gives you, it's a useful tool to help identify people whose health is deteriorating and assess them for unmet supportive and palliative care needs. And within that, it talks about advanced care planning. There is a link there for you to follow. We'll have a quick look. There's another tool, again, just to have a look, explore them. I'm sure you're using different tools as well, but these are just something else that may help you indicate the patients that would be most prioritised to have these conversations. If we just have the next slide, please. GSF is also another one, again, another proactive identification. Within that, again, it's very wordy, apologies, it looks terrible on a slide, but it is, again, another tool that you may want to have a look at. Next slide. Okay, so facilitating the conversations. When we watch a video that's 3 minutes long and it says it's 5 simple steps, it can really almost feel like it is a very simple process, and why aren't we all empowered and confident to do it? But actually this can be difficult work, and it feels difficult because it is difficult at times, but it's also incredibly important. We do have the skills to do this. We have this with, you have the skills within your teams. It's certainly something that can be taught, but the more we do it, obviously the more confident we will get to doing it. And you will have good experiences, and you will also have bad experiences of trying to facilitate these conversations. So before we move on to talk a little bit more about facilitating conversations, I cannot stress to you enough, and I'm sure you are already doing this, but these can be difficult and they can be challenging, so we must look after ourselves. We must have compassion for ourselves and each other along with our residents as we enter into these conversations. We have the next slide. So these are just some key phrases that I thought I would share with you in regards to opening up these phrases. If we arrive into a residence space or into a patient's room or wherever you are seeing this individual, waving a respect form, and you enter into it because I've got to complete this form and I need to talk you through this together, you will find it a very difficult conversation. It will probably feel professionally uncomfortable, and I would imagine for the patient and resident it may feel also uncomfortable. So we need to think of a way that we do this, and we adapt the way that we do it. You need to find something that works for you. But we always tend to start with what do you understand about your illness? And often sometimes you just have to say the right sentence at the right time, and it will hook you into this conversation and it will flow much easier. Do you think or worry about the future? Have you got any questions about what might happen as you become more unwell? Have you talked to your family about the future? I always like to think about the population of people that have always got a to-do list, that are always planning things. And then as we come to maybe a more natural slowing in our life, or we move into different settings, some of that planning maybe not feel as important to them, or it might not be as relevant to their day-to-day life, but they've always been a planner. They've always been a person that liked to plan ahead. This is, again, another opportunity for them to return to that skill. So ask them, is it something, have you always been somebody who likes to plan? If so, have you thought about planning what would happen to you in the future if you became more unwell? Make sure when you go in that you are aware of their illness and that you've done all of your background work. I'm sure you'd do that anyway. Have a clear idea about what their priorities might be. We have a look at the next slide. We must be really careful with our language when we start these conversations, especially if we are entering into these conversations potentially on the verge of a crisis. We naturally want to believe in a world where all of this is done ahead of time. There will always be an occasion where we can see somebody has had a rapid deterioration, and maybe these conversations haven't taken place, and we may be having to have these conversations with somebody who is most close to them. So we must be really, really confident with language we use. So we need to say things like might not survive the night or week. We are worried we might not be able to save her life this time. I fear he is now too sick to survive. I fear he may not live much longer. He may be dying. We need to get really comfortable and be champions of using the right language. I think we do. It comes from a good place. We use language such as slipping away or that we've lost them now, and that comes from a good caring place. But actually, when we're having these conversations, we need to be using the right languages. And if we can't get that right in healthcare, we can't expect society to follow. We need to be the champions. You look and sound worried today. Are you able to tell you what is worrying you the most? Are you able to tell me what's worrying you the most? These are just some simple sentences that are tried and tested, and that you may find a much softer way to enter into these conversations. Quite often it is starting the conversation can be the most trickiest. Once you're in it, usually your patient, your carers, your family members will start to guide you as you help and hold and facilitate the conversation. If we have the next slide, please. So in the context, we need to focus on patient priorities. Have you thought about what treatments or care you would want if you become more poorly, or treatments you wouldn't want? And this goes back to my very first question I asked you. Is ACP always about patient choice? It's a big topic. The truth of the matter is, when it comes down to patient choice, them sharing their views, they are free to share their views. But when it comes down to treatments, nobody can demand a treatment. Nobody can demand to have a treatment that would be deemed medically, I don't like the word futile, but I'm going to use that word because it homes what I mean. Futile, would cause harm, would create no benefit. So there is a balance. That's why we need to know our patients and our residents before we have these conversations. And we need to ensure that we're not going into it with they've got this wish list of what they may want, but actually what we need to know is what is on offer to them. And that's where our skill, our expertise and our knowledge as healthcare professionals comes into it, is that we're able to guide them to say, this is what would be on offer to you. What is it that you have you considered what you would want if you became more poorly? And of course, sometimes when you enter into that, quite not often actually, but you can find yourself in a situation where you'll have a resident wanting something that isn't going to be an option to them, and then you are entering into breaking bad news. And I think we need to be really mindful of that, and that is a skill that can also be taught. It's a complex conversation, it's an advanced communication skill. So if you don't feel equipped to be able to manage or break bad news, then that is a further skill that needs to be invested in, to be able to do these conversations well. It talks, so do you have hopes or fears of what that you'd like to talk through? Would you like to think this through together? Do not go into this conversation thinking the only outcome is a completed DNA RCPR form or a respect form. It will come across not organic. It will come across ingenuous if you have gone in there purely waving a form to have this conversation. That is not the only outcome of an ACP conversation. Naturally, if what you have discussed and you have uncovered, remember this is a voluntary process that many people do want to engage in. They want to share their thoughts and feelings. They want to know that when they can't have the capacity to share with anybody, that their thoughts and feelings will be followed through. But do not enter it in with the only outcome is that I've completed a respect form. And often these conversations happen over several consultations or several contacts. But this again is you. I keep rattling on about this like a stuck record. It's about allowing them to discuss their hopes and fears, and you guiding them from your professional in regards to what is available to them, what is clinically available to them, and how do we guide them so they understand what is available to them. And ideally we come to a negotiation that we've got a really good advanced care plan that is the patients, they own it. Find a language that is yours. If we have a look at the next slide. So So that is a little bit, that's a very whistle-stop tour about how to manage those communications and how to handle what can be sometimes very straightforward conversations, but can also be a negotiation, can also be breaking bad news, can also be really complex, can be highly emotional. So apologies, I've given you a whistle-stop tour and made that sound so easy. But let's move on to the documentation. So again, really, if we just flip back to the other slide. Thank you. Very quickly, ACP, I'm going to go with lasting power of attorney. I'm going to make an assumption that all of you have had some idea of lasting power of attorney, but it is a legal document. It requires a solicitor or lawyer involved. It's costs money. I don't want to give you an exact cost, but I think it's about £100. I'm sure the solicitors can't charge you way more than that, but I think that's about the going rate. You can get lasting power of attorney for health and wealth. If somebody says to you, we're the lasting power of attorney, make sure we get a lot of it at the hospice. People will say they're the LPA, but actually they're the next of kin. And I don't know why that language gets confused, but as I'm sure you would do, make sure you see the document, because like I said, you can have one for health and one for wealth, and it's naturally the one for health that we are interested in. Like I said, it's a legally binding document, only comes into play when the person in question loses capacity. So it is completely just a document that stays dormant until that person becomes not able to communicate their own wishes and wants. Advanced decision to refuse treatment, really rare. Again, it's a legal binding document. So LPA legal binding, advanced decision to refuse legally binding, needs a solicitor, also needs medical input, much more costly. Both of them take about, I want to say 12 weeks to go from initiation to completion. They're not quick fixes. So they do need to be done in advance. And usually, again, your indicators are people who you would expect through their disease trajectory to lose capacity. Advanced decision to refuse treatment is we often see in our MND groups, our Parkinson groups, dementia, or people that do not have somebody within their life that they would nominate as a lasting power of attorney. We see it a lot around artificial feeding, artificial ventilation, and IV antibiotics and hospital admissions. Rare, but they are out there. And a much bigger subject about why would you have a lasting power of attorney if you had an ADRT and an ADRT versus an LPA. We could talk all day about that. I haven't got time. I'm hoping we might be able to do more of this anyway. Advanced statements is a GSF document. DNA CPR, which was our old road forms that have slightly been phased out. I haven't seen one for a long time, but I do live in a hospice bubble, so appreciate you guys might see more of them, but we've definitely started to see over the last couple of years DNR CPR forms being phased out, respect forms being fed in, so they're the ones with the big purple border. We're going to talk more about that really quickly. Teal is your UHB form. That is an inpatient document. Pre-COVID, they were kind of being sent home into the community, and they weren't as relevant because they talked a lot about ward-based care and the language wasn't as transferable. At the beginning of the first wave, I believe UHB did make a real big stance to say we'll use Teal because Teal is compatible with their internal IT function, from what I understand. But anybody that has a Teal in hospital will then be sent home with a respect form, which is what we should be seeing. And I have seen that, so I hope you're seeing that. And if you're not, then we need to escalate that back into UHB to make sure that the right documents are coming out on discharge. So we're going to have a quick look at respect. So these are the respect forms. We'll have the next slide. I hope I'm not teaching you all to suck eggs here, but we are going to go through this. This is the most latest version of respect. We have been using respect at the hospice, I've got to say, for about 3 years, and they do every now and again create a new version. I really, really like this document. It is such an empowering document. It really allows residents to share their thoughts. Remember, this is a live document. It belongs to them. It doesn't belong to us. It is not law abiding. However, if for some reason a resident had one of these and their wishes were not adhered to and this ended up in a court court scenario, you're going to have a really good reason why you didn't follow it. But I wanted to make that clear, the difference between legally binding where it's gone through a solicitor and one that actually this is a live document that we are able to facilitate and help our residents fill out. So you can see section 1, just really simple, straightforward, name, address, etc. Section 2, shared understanding of my health and current condition. So this is where we often see dementia, just dementia, that's all we get there. This is a document. Imagine this person has been found, nobody knows them, and this form is just there, but they're unconscious, they can't speak for themselves. Let's write something in section 2 that doesn't just talk about their diagnosis. Let's write something in there that tells us about that person. So yes, they've got dementia, or yes, they've got end stage renal failure or something. We need obviously a medical diagnosis in there, but let's write mom of 4, loves her family, or you know, something, had cats, something about that person that if we were to come in and trying to give that person some care and we wanted to show that we knew a little bit about that person, let's have it in there. So, you know, again, you're going to make a negotiation. This is done in advance. This is when your patient or your care or your resident is capacitous. So let's negotiate what they want to put in there. I always like to have a little bit of fun, to be honest. They're like, I've got patients over the years that, you know, they always want to be shaved in the morning. They always like a certain moisturizer or a certain perfume. We've put some really, really personal stuff on there. So if somebody knows, if you find me, this is who I am. This is who I am. Let's not lose that on this document. So we've also got then details of relevant care planning. So there is a section there where we can put if they've got a lasting power of attorney, a welfare proxy, an advanced directive, that sort of thing. So we can definitely put some of the more serious stuff in there that we can say, look, I've already had these discussions and there's more to it, and this is where you're going to find it. Now, section 3 is what matters to them. So this is where you've got your hook. So I've spoke to you about some of the opening sentences about, you know, what's important to you. Have you thought about the future? Do you worry about the future? So it gives you there a bit of a line where they can almost put a cross if they wanted to. Again, we don't tend to use that for many of my patients, but if they wanted to put a line, so you'll see this side, it's got quality of life and comfort matters most to me. So if that was the only thing that mattered to you, you could in essence put a cross right up in the corner. However, it's got right down the other side, living as long as possible matters most to me. And then we've got the 2 boxes below, which is where we use much more of the patient's information. Obviously, they can write it themselves if they wanted to, or you might be writing it for them. What I most value. So what I most value is, you know, that I'm cared for at home, or that I'm cared for surrounded by people who love me in familiar surroundings. What I'm cared for most is that I think of one most that I don't want to be messed about with. And obviously I know what that means. I don't want to be poked and prodded. I don't want all these injections. I don't want people coming and messing with me. So again, we can write that values most to me. And of course what I most fear and what I wish to avoid. And again, most of the time we're saying what values most to me. We tend to get themes like dignity. I want to be pain-free. I don't want to be relaxed. I want to be surrounded in familiar surroundings. What I fear most is usually the opposite of that I want to be in unfamiliar territory. I don't want to be surrounded by strangers. You know, so really being able to open up those conversations, what I most fear. I don't want to keep going out of hospital. My last admission was terrible. I didn't enjoy it. I didn't feel, you know, it was valuable to me. So that is where we really get our residents' thoughts and feelings. And then we come on to that number 4, which is our clinical recommendation. You will see there are now 3 boxes. That is new. You've got one where we are just prioritising comfort here. This is exactly what that patient wants, and that fits in beautifully with my clinical view of this person, that actually let's prioritise comfort. We've also now got the prioritising balance extending life with comfort and valued outcomes, and we've got prioritise extending life. So we would be signing your name in the relevant box there, and then as we go down you will see there you've got another box where you would give your clinical guidance. So we're talking about ceilings of care in essence. So we're talking about you know, discuss with patient, but actually, you know, we feel that it's we're not for IV antibiotics, we're not for readmission unless it was something that was, you know, treatable, and, or, you know, IV antibiotics was appropriate, or actually we just want oral antibiotics, that's all this patient wants, and we feel that would be appropriate. So that is about your clinical guidance. And, you know, when I said about earlier, you know, we need to understand what those ceilings of care are, and if we don't understand that, if that is out of your scope, this is where we need to be liaising and linking in with the right people. Your MDT is important at this point. And then you'll see this tiny little box down at the bottom, which I'm really pleased, because obviously we used to just have one big red form, and now we've got this tiny little box. And we have a CPR, just a little box where you would sign that actually we've had a conversation in regards to resuscitation and we do not recommend it. So again, we are talking to our patients at this point, but again, CPR is a medical intervention. It is not something somebody can demand. It is something that is, if we deem it that it's going to do benefit and good for you, and it's not going to cause harm that doesn't outweigh its benefits. So we need to again be having those confident conversations that we understand how to discuss do not resuscitate with our residents, so we can sign that. And again, this is the same in an ideal world. Section 3 and section 4 marry up. And in essence, to try and get to the point of completing this form, section 3 and section 4 marry up. Sometimes we're just not in that place. And that doesn't mean this form doesn't get completed. It means that you might need more conversations. But if you've really got a resident who's saying, no, I want to be resuscitated, or I want, you know, to go to ITU, and as a professional or from the MDT that just isn't appropriate, then we have to go to a second opinion. So that is the same that we would do with any other medical intervention. If we were saying to them from our medical profession, from where we stand, looking at what I know about you, that these are your treatment options, and if that patient's saying, well, that's not good enough, I want more, I want this, then we must refer on for a second opinion. That's how you manage this situation. If after all the skill you've used and after all the negotiation, you're still not able to get to a place that would be a it's voluntary and that your patient understands, then we do need to be looking at second opinions if we find ourselves in those situations. And that's when this becomes really complex. And this is where you do, that is one of the reasons why you could refer to palliative care. Which we're going to talk about referrals in a little while. And then on the back, it talks very much about capacity. So I've spoke to you the whole way through majority of this training as if your person has got capacity, and there's a really clear box there where you tick yes or no. If for some reason we have got to a point that we need to complete advanced care planning, it's in the best interest of this person that we have an advanced care plan in place, they are deteriorating patient, then we really need to make sure that we have consulted the right people when we come to filling out this form, and we've done everything we possibly can in our best efforts to consult with the right people in regards to that individual. So if you've got a resident who doesn't have capacity, if you fill out this form as a best interest and I'm going to fill this out and you have not made any attempt to contact somebody that would be important to them, so whether that's a family member, a carer, whoever is their important person, then this is where this becomes unstuck at a later date if things ever went down that court route, which I don't like. We don't want to focus too much on that, but this is one of these documents that can often do that. And where cases have gone and there has been issues around that is when family members have found out that a form has been completed, be it a DNA or CPR form or a respect form, and they've had no consultation, and it doesn't work out well. So do everything you can, and there's even a box on there to say you have consulted if there is a significant other person or a legal proxy or relevant family member. Number 7 is where you get to sign. You will notice GMC, NMC, HCPC, your physios, your pharmacists, your OTs, they can sign this document. It does not need to be somebody, it doesn't need to be a doctor or a nurse. It needs to be somebody who has received relevant training. That is your guidance. Some of the best people I've worked with who lead on these conversations is actually one of our band 3s that work in day hospice. She can't sign the document, but she's amazing at instigating the conversation. So use your workforce and make sure everybody around you feels skilled up to do this. Clearly, you need to be a registered healthcare to sign the document, but actually to initiate and start the conversation, it doesn't need to be any of the above. They just need to be relevantly trained. You've got emergency contacts, and then of course you've got a review at the bottom in box 9. I would say good practice, somebody coming into your care home for the first time, if they've already got one of these, even if it's only been done a couple of weeks ago, have a look at it and review it, make sure it's still relevant, even if it's just a couple of weeks ago, and sign and say you've done it. I would say that was good practice. If anything changes in that person, they've deteriorated, their change of home or next of kin has changed, anything like that, it's a really good opportunity to review. Next slide. Just a refresh. I feel like I've talked very fast at you and I'm probably way over time. I'm very sorry. So respect includes details of treatment planning, ADRTs, advanced care plans, priorities for care, comfort versus sustaining life, escalation of care, CPR decisions. It is a live document. It is patient held. They own it. We don't. We must make sure we communicate it across the system with all the people that are involved in care. It's valid in all settings. It's a details on the form need to be communicated on discharge and a change in place of care. Sounds easy. Next slide. Can be completed, I think I've covered that, can be completed by any registered healthcare professional who's involved in the care. The form is a summary of a detailed conversation which could have occurred over multiple consultations. This must be recorded in your notes. Filling out a respect form, ACP done. No, you have to put it in your patient notes. I'm sure you would do that anyway, but you have to put it in any of your medical notes that you would be recording to say this conversation's happened, please see respect form. But these conversations, and this is what was discussed. Next slide. Really quickly, as I am here from the hospices, just a referral to palliative care. It is much simpler, I hope, as now than it has been for quite some time. So for patients, residents who have specialist palliative care needs, you absolutely can refer to the hospice charity partnerships for any patient over the age of 18 who has a life-limiting illness where there is no reasonable hope of cure and they have palliative care needs. So referrals can be made by a range of healthcare professionals. There's a list there, but obviously care homes are included in that. When a patient's, and the other thing I wanted to let you know about referrals is we manage complex symptom management that we are struggling to manage elsewhere. So the GP can't quite manage it, or it's a complex patient. We will come in and hopefully get a good treatment plan sorted out amongst our teams and with the patient and the carers. We may stabilise that patient, and that patient, although will still be a palliative patient, may be a stable palliative patient. So do not be surprised if you refer somebody to us and we come in, get a good treatment plan set up, and actually they enter a period of stability and we may discharge them from our caseload. It is really easy to have them put back on the caseload, though. You don't have to go back through referral processes, etc. It is an easier process, but actually we do see patients who are referred to us, stay on the caseload, get stable, stay in a stable place for months, weeks, days, hopefully a bit longer, and then they can then be put back on our caseload. We have the next slide. So referrals to our services can be done using one form, which you can find on our website. Healthcare professionals can refer to all patients to the following services: community palliative care services. I says excluding day hospice. Day hospice is now just about to reopen, thankfully. So day hospice, keep an eye out if somebody does need some of the day hospice interaction that we offer and the education that we offer. There is a hospice at home, which I'm assuming probably wouldn't be as relevant to this particular audience, but inpatient unit. And all referrals are being managed by a HOBS, which is Hospices of Birmingham and Solihull. You can download the referral form, you can find it on our website, and you send it to that email address. We go on to the next slide really quickly. That's kind of what the form looks like. It is pretty self-explanatory. Do not worry about sending a form. If it is not an appropriate referral, we would rather have, and I checked this before I came on, we would rather have referrals that we're like, actually, this probably isn't appropriate for our service at the moment, but we will help you redirect that patient, or we'll give you some advice, or alternatively, of course, we'll accept the referral. So do not be worried about referring. There is an advice line there, which that telephone number is 24/7. We have 10 lines. We are able to offer advice to yourselves, to your care homes, to your registered nurses. If you've got a patient that's, you've got to worry about a drug concern, or you've got to worry around how to manage a certain symptom, or what do you do with them, pick up the phone. They are really approachable. They are there to support you. We are part of the NHS family. That I think I've just stole Claire's phrase, but I loved it. We are part of the NHS family just like you, and we should be supporting our patients together. So do not feel fearful to pick up that phone. I'm sure you would be greeted by somebody who would be willing to support you, and it's 24/7. And if we find that actually the support doesn't need to come from the hospice, we will help you navigate where we go with that patient. That is me done. I'm so sorry if I've gone over. I did say it was quite mean feat to get that done. I can see loads of stuff going into the chat. I haven't been watching it, but any questions?
There were a few things in the chat, Camilla. Nick raised an issue about they've seen quite a number of residents coming back out of the trust with a teal form rather than the respect forms, and I have responded to him. They're obviously dealing with that and completing a respect form, starting a respect form for some of those residents, but that's not getting to the root cause, and I've suggested that he maybe contacts the resource officer and completes an incident form when that happens.
The chap that was leading on that is the lead palliative care consultant, Dr. John Speakman, and his team. So it was the palliative care team at UHB that were leading on that at the very beginning of the first and second wave of COVID, where clearly we were all trying to do as much as we can to ensure it's streamlined. I have seen some of it, but I'm guessing, as you can imagine, there's cracks in that system, isn't there? You can see where this is going to break down. So it's really important that we do feed that back. And I'd imagine, yes, the resource officer. I do work with John Speakman, and I can bring it up as well to him.
That would be great. And if you come back to us, we can pass that on, but come back to Nick. That would be great.
Yeah, no problem. I will pass it on to the palliative care team.
Sorry, I didn't want to. It was just also to add, thinking back, Caroline and Camilla, often it's the step down units where they're sending them out.
Right.
So
okay.
it might not be just UHB.
No, it might not be.
The step down intermediate care beds owned by UHB.
Lovely.
Yeah, even more. Well, I mean, again, I can flag that up to the palliative care lead at UHB, because I'm sure he may have some influence on it. But that's really interesting, Nick, to know that that's, potentially where the breakdown of process is happening.
Lovely. The other question that I put in myself was when you said the respect form needs to be completed by a healthcare professional. So can you just clarify who you mean by that?
So it's anybody that holds a registered, I mean, nurses call it PINs, we call it registration. I think doctors probably call it reg as well. Anybody that holds, so you have to be GMC, NMC or HCPC.
Right.
And
so
to be honest,
so for a residential home that might not have that, it would probably be the GP.
Or you need to refer this to the GP. Absolutely. It needs to be the GP. And I think again within GP practices we're seeing. I mean, I know recently we've been training a lot of the primary care paramedics who are also taking on some of this workload. So it might not necessarily be the GP within the practice that needs to lead on these conversations, as I said, and lead on the documentation as well. It's everybody's business, isn't it?
Yeah, absolutely. That's been extremely helpful. We obviously have gone a bit over time.
Sorry.
No, don't be sorry. I think it's been really worth it, and there are some it's been a really good detailed, practical advice for care home staff. So thank you so much for that. And thank goodness it's recorded. So we'll move on now to, I think we've got Alka next, who's a care home manager of the Prince of Wales Nursing Home, who's been putting some things in the chat. So Alka's just going to share some of her experience about implementing the Restore 2 model in her care home, and she's going to give us an example of how it's benefited, a case study where it's benefited a particular resident. Thank you, Alka.
Thank you, Caroline. I'm a registered manager, been at Prince of Wales for the last 15 years. We used the Restore form in 2019, end of 2018 and early 2019. And Kelly's team, who's spoken earlier, supported us. She came and trained all of us together, which helped so we could get each other's support as well. She didn't just leave us to it. She just handed me, to be honest, as a manager, and she asked me if any of the nurses were struggling. And what she did was she sent her nurses when my nurses were on duty, so we didn't have to spend extra time. It's just she took 10 minutes, they came. We did have only on one aspect is confusion or dementia. We were scoring everybody high. So if you've got the Restore 2 forms, you'll understand that. There was only one issue with that. My issue was end of 2019, no GPs were using it. We ended up doing admissions and my nurses were saying, we are wasting our time because our GPs are not recognising it. However, on a positive note, when we called the emergency services, they'd recognised it. They were aware, they knew the GPs weren't coming out and we weren't doing unnecessary admissions. The hospitals did. If I wanted to readmit a patient or resident, we were asking the scores, and so we knew that where they were before and where they went. So advantages for us managers, what it is hospitals and paramedics recognise the tool. They've been using it for I think over 4 or 5 years. Service users, they receive uniform to your care between the nurses. You might have nurses who will be saying, oh, this person's okay or this person's improved, but when they actually do the observations, you'll exactly know where they stand. It avoids hospitalisation by recognising early signs and escalating to the GP in real time, and I think everything's happening in real time at the moment. By making a baseline of scoring for the individual, and then by using the tool on a monthly basis, when the care plans are updated, and then escalating to GP as a first point of call. The Restore 2 form is recognising early soft signs, taking observations, responding and escalating. I got involved in the project and Restore 2 was the document which was picked, and I'm glad because I don't know if you were in Solihull, you'll know Red Bag Scheme. People have great ideas and they don't follow up, but Restore 2 I think is a great tool which is at least used by 2 big I call it firms, but by NHS, and the community team are aware of that as well. Lastly, when I got involved in the project, I got my nurses to take the observation sheets out again on a monthly basis, start using the Restore 2 form so we can recognise early signs by taking regular observations and making baselines. Caroline's asked me to share what real difference it's made to one of my service users. So just giving a scenario, I think everybody knows during COVID, I've got Paul and Mary. Paul was coming to live with us. It was a very short placement, 9 weeks. What happened is Mary was a nurse, is a nurse. She looked after her husband at home for 4 years after a tragic accident where she was driving. She was guilty. He ended up being transferred to a residential home, where I think if you're from nursing homes, some people don't think it's residential or nursing. He went to residential home, then he went to the hospital. The wife was really, really stressed, came to us. First thing, if you admit, no hospitalisation, which is a real pressure on us managers as well. He came to us 23rd of the 8th, and the wife she had his wishes, we did end of life, we do. So I'm bringing up everything what's been said in the slide is patient's wishes, end of life, continuity of care, using the tool. So I didn't realise this, or what do you call it, my scenario would bring everything together. So the wife's wishes was no hospitalisation, as she'd cared for him for 4 years, she wanted to be by his bedside. So on 27th of the 8th, by the time which is 3 days after we've done the observations, Restore 2 was completed, and the GP was called straight away. It was Friday afternoon. He visited, prescribed antibiotics, and met the wife as well at the same time. So GSF coding was amber. After that, weekly the GP had reviewed. 6th of the 9th, Paul had slightly improved through, but his SATs were low, so our GP knew where the baseline was. He didn't know Restore 2, but he knew from where it started. 6th of the 9th, he did another full review, slightly improved again. 20th of the 9th, another antibiotics were prescribed. 28th of the 9th for UTI, and 8th of the 10th, sadly, he deteriorated. When he deteriorated, paramedics were called. They knew, we spoke to them, they had the history, they knew his coding was amber, they knew how he was deteriorating. They called our GP on our behalf, and we said no hospitalization because it was a sudden deterioration, but it might have been sudden because paramedics were called. Well, we had a history. So in a matter of 9 weeks, by starting the Restore 2 form and having baseline, we didn't know anything about this gentleman. And you know, guys, between settings, when we change our GPs, it takes 6 weeks for them to transfer the, the medical notes, even though I get a printout before the resident is moved from one place to the other for us. Our help was the wife knew a lot. So patients' wishes were really taken into account. So by using the Restore 2 form and GSF coding, Paul's hospital admission was avoided. His wishes, his family's wishes, he died. Mary, she stayed with us that night, even after Paul passed away. He passed away like 11:30 at night from 10 o'clock in the morning. Again, I think it's who's given the, about the end of life. The family's wishes was, we're not invited, we don't want any priest, we're not religious. So many people I've known changed their mind. I still ask them. It took me an hour and a half to get a priest. By the time they said, where is he coming from? I didn't even know. He was a Catholic priest, thank God for that. We'd read the last rites. So by saying this, I think if we've got uniformity in our care between all the services, my gripe is the GPs. GPs are first port of call. So this project is to get the GPs on our side who can support us weekly basis before even we get to the point of ringing that number to say we need a paramedic out. I think I'm done talking. Any questions, guys? I don't know, Caroline, that's enough. But
thank you, Alka. That really is a great example of both your experience of implementing Restore 2, but the benefits and the power of that. The use of the tools and the collaborative approach that ended up in a good death for that resident, with respecting his wishes and remaining in the care home. So thank you very much for that, Alka. That really appreciate, and it really followed on nicely from Camilla's session, which was equally as excellent. So thank you both for that. That we're really pleased. We're going to move on now. It's sorry, I do feel that I don't like to rush on, but I'm conscious of time. So we're going to carry on with the slide deck now and just try and pull this to a close, with the last few slides. So next slide, please, Naz. Next slide, please, Naz. Thank you. So obviously our aim is that we want to improve the recognition and management of deteriorating residents in care homes by implementing the Restore 2 pathway in the Solihull care homes and the Birmingham concept homes. And how are we going to know that we've done this? How will we know that we have made those improvements? Next slide, please. So thinking about what we're trying to accomplish, how will we know a change is an improvement, and what changes can we make that will result in the improvement? Well, our aim is to improve early recognition and to increase the number of residents staying there in their preferred place of care. And so some of our measures will be local measures, so the number of staff that are trained in Restore 2, or have had, you know, training on how to do respect form, etc. Those will be the local measures that you can do, but we'll also have some outcome measures in terms of ambulance call outs, numbers of residents conveyed to hospital. So we are looking at those, we are tracking those measures, and hopefully we'll see a decline in those numbers or an improvement in the numbers of residents staying in their preferred place of care. And the changes that we can make are the changes associated with Restore 2. It's about implementing that tool in your care homes, you know, in small stages, getting staff to use the SBARD approach when they're escalating concerns, so that the people they're escalating to can make the most of an informed decision based on the completeness of the information you give them. Next slide, please. Next slide, please, Nav. Thank you. So thinking about where are you now? We've got 6 homes on the call, and we've had some comments in the chat. Some people are using News 2. Some people are, you know, are familiar with SBARD. So where are you now with this? So are you undertaking frailty assessments? Do you know? Have you got a process in place where you know when all the residents assess for frailty on admission, and you know where, you know, what stage of frailty all your residents are? Have staff had training in the Rockwoods frailty scale? Earliest recognition of soft signs. Do you using the Restore 2 pathway or the Mini to escalate concerns? Have you got an SBARD prompt by your telephone, so people are, you know, prompted to remember to use SBARD? Have staff had this training? This is training that you can use. You can disseminate this to your staff. And clearly, the Camilla's presentation about the, you know, advanced care planning. This recorded session you can show to your staff. This is part of your training pathway. If you're a nursing home, are your staff trained to undertake observations? Do they know how to calculate a News 2 score? And end of life planning, I've already mentioned that. And the slot that Camilla did, it actually would be excellent training for your staff. So just think about where you are now, and where, you know, it's a stepped process, and we need to tackle each thing, you know, and everybody will be at different stages of this. So, you know, have a think about where you are, and, you know, when these slides arrive, you can sort of maybe put this up as a bit of an action plan for you and your home. Next slide, please. Next slide, please, Naz. Next slide, please, Naz. Okay, and I've already mentioned some of these measures. So think about, you know, the measures that you can collect locally, but also how that will, obviously there'll be some regional measures that we can look at, and it may impact on your staff satisfaction, your resident satisfaction, complaints, incidents. You know, all of these are, it will be outcome measures that and it will improve the culture and communication in your home relating to deterioration, recognition and management. Next slide, please. And some of you may already be using safety crosses for things like falls or UTIs. We have a deterioration safety cross. For those that don't know about safety crosses, this is a the cross in the middle represents the days of the month, and you complete one of these every month for your care home. And each day you colour in the day of the week, the first, the second, the third, according to how you're doing. So if you've had no hospital admissions, then that would be a green day. And this is a really great visual aid to help staff see how they're doing. So over the course of the month, you'll either have a sea of green or a number of reds or ambers. So you can track how you're doing with that, and these resources will come out. It's just a very visual way for staff to capture data on a daily basis. At handover, did we have any hospital admissions or ambulance call outs yesterday? You know, you can colour in the cross and see how you're doing. Next slide, please. And we know that care homes that have undertaken projects where they've improved recognition and management and implemented a tool like Restore2 have seen a significant reduction in their ambulance call outs, and they've tracked where that improvement has you know, where they've had interventions, like they've introduced the soft signs recognition that resulted in a reduction. And then when they did their frailty scoring and started that advanced care planning process that Camilla mentioned, where you start to have those conversations and residents say, you know, you may not want to go into hospital, and then staff are more able to adhere to their wishes. Again, that had an impact on ambulance call outs. So that's just an example how you can track that, and you can use your safety crosses to capture that data over time. And this is all really great evidence for CQC that you're well led, responsive, safe and effective, providing an effective service for your residents. Next slide, please. And so that we've sort of come to an end, and I've wanted to leave a little bit of time for questions or just a bit of a discussion. Thanks for taking part. You will receive all the slides today and the recording of the webinar and the chat log. We'll send that out in the next few days. But we'll just come back to the participants now, and please feel free to put your cameras on now and ask any questions you have. And I'm just going to try and catch up with the chat log now to see what's been good. Yeah, so should we start with the frailty assessments? It would be great to hear. Are you undertaking frailty assessments at St Joseph's, Burwood, Meadow Rose, Hafford and Prince of Wales? Just give us a bit of a feel for how you're doing with that. That would be really great. Be brave.
Hello, I'm brave. We're brave, yeah.
Brave, thanks, Stephen. Is that Stephen?
Yes, it is. Hang on, let me try and put on my camera.
Stephen, put your camera on so we can see you. Thank you, Stephen.
I'm brave.
Yeah, we can see you, and we can.
Can you see me there?
Yes.
All right, thank you very much. Yeah, I'm with my clinical lead here as well, Sirani. Yes, the frailty scale tool that we've been using is News2. That's something that we've refreshed our training as we go. It's worked very well, and to add on, in addition, because we've got a service with a GP who visits every Wednesday, we've noticed that it's having an impact in terms of reducing the number of times we're having to call the ambulance. And also referrals to hospital. A lot of people having treatment within the home, which is great. Even the support for end of life has been absolutely fantastic. And, the team at St. Mary's as well, can't praise them enough for being available on the other end of the phone as well, whenever we need, to consult for advice. So overall, it's working on very well, and it's embedded in the electronic system that we use at the moment, the News code. Yeah.
Brilliant. Thank you so much. That's really great to hear. And I just picked up on Karen's comment in the chat that they're doing, they're using at Burwood, using frailty scores, News2, advanced care planning is at the point of pre-admission assessment. So that's really great news. Thank you so much, Karen, and keep up the good work. So brilliant. Oh, but that's fine. She's got no microphone, but you've put all the detail in the chat. So thanks, Karen. We really appreciate that. Any of the other care homes? Obviously, Alka's care home is is using all the Restore 2 tools as she's shown. But what about the other care homes, Hathord or Meadow Rose? Would you? I mean, it's okay if you're not yet, but you know, we'd like to hear if you found this beneficial and what your plans are. That would be great. Maybe you don't have a camera or a mic. Or Rachel Bilkeys. Don't know whether you're able to contribute. Don't worry if you're not. Okay, so I think we're sort of at a point where we can did Camilla, did you want to say something?
Yeah, I just noticed there's a little bit of a theme in the questions that I haven't quite answered in regards to the response from the hospice from education. We did have a really big programme. Well, it's awful talking about history. We did have, this is what you could have won. We did have a really big programme of care home education response. Unfortunately, our funding did come to an end. However, we have received that there is a likelihood this is going to be picked back up again. The best place to find our training is on our website. So we've got a big education page, and if you head over there, everything is on there and you'd be able to book yourselves on. Most of it has been webinars. We have done some clinical shadowing as well, but unfortunately we are just waiting for it to be funded back up again. But do have a regular check on the website, because any training courses are available there.
Brilliant, thank you. I think that was my question in the chat. I was trying to preempt what people might be thinking. So
would it be possible just to put the website
chat so that I'll pop it in there now? Yeah.
Thank you.
So Claire, I don't know whether you want to come in at the end there just to because I think it's been a really great webinar, and I think the resource, the recording will be extremely valuable to share with the care homes that have obviously attended, but the ones that were unable to, that will receive the recording. So I don't know whether there's anything you wanted to add at all, Claire?
Yeah, I suppose just to say, for the ones that haven't perhaps been able to speak, who are here, what it might be good if we could incorporate into our plans is a call to those CAMs, because I think it'd be really useful, or all really, to get reflections on the usefulness of the session. And also, and you know, for me, I'm really keen to hear on and what else really of how we can support care homes. So we can bring that into our plans, can't we, to how we wrap around that follow-up really. Bearing in mind there's only a small number, and also to consider with other care home managers how we perhaps engage more people next time. I recognise you know, we're a nice, small and friendly group, and it's fantastic to have people here who we have here today. But there are lots more homes out there, aren't there, that we really want to be able to reach, and how we do that. You know, any thoughts from yourselves, because I'm sure you've got little networks yourself. And again, that honesty and openness. This isn't about tripping anybody up. This isn't about, you know, if you're not using them, it doesn't matter. It's not, you know, we won't be criticising you. It's what can we do to support you, and we truly want to do that. So we'll bring that into our discussions. And then I suppose it's just to thank everybody for their contribution into the chat. A couple of the actions that have been highlighted to me, I've already set up a discussion with Alka and sent an invite to Kelly just around the discharges and how we can connect in. Kelly probably hasn't seen it yet because she's sat further away from her laptop than me. So that's for tomorrow. Just, you know, so we do mean business by this really, and we really truly want to support you. So, you know, for me, we could all go to many other meetings during the day, but for me this is really important. And you know, what else we can do, please, you know, consider it and share it with us when we catch up with you in however we do going forward.
I mean, just thinking about that, I'm conscious that we do have managers forums, and that might be a route into spreading the word. If managers could raise the issue that they've attended this kind of webinar and these resources are available, and the recording, that then, you know, spread the word amongst the manager sort of network that this is available, or you know, there are lots of resources available to them, that might help with spreading the word about the, you know, the resources and tools that are available. So thanks for that, Alka.
The only other thing from me is, again, just to thank, I don't know if the colleagues are still on that worked with Nick on the case study that was shared. I don't know if they are or not. But just to say thank you to them again. I know I did phone at the time, but just to reiterate that thanks once again for, you know, that stepping outside the box really, and supporting those residents to stay at home safely. And as we've said throughout all of this, it is about safety, and we wouldn't want to compromise anybody's safety whatsoever. We're in support of all of that, but it's that earlier detection and prevention really. So, you know, and thank you to all of the speakers as well, because without everybody here we couldn't do this. And so a big thank you from me on behalf of the system really. I'll shut up now.
And thank you for your time, everybody, and you've got 4 minutes of your life back, so please feel free to hit the red X button and go and do something more important.